Good morning, everyone. I think for most of you, it's bright and early, so welcome. We're glad you're here. I am Nan. I work with ACHE in the Chicagoland area and have been doing so for about 4 years now, since the start of COVID. These events are awesome. I love them. So I'm glad you're here. Just as a part of my housekeeping, I'm going to give you a few things before I turn it over to our chapter. But on behalf of the chapter, the Oregon chapter of ACHE, we welcome you to today's event. Um, I am going to be here for the duration. So if you need anything at any time, just reach out to me in the chat. I'm happy to assist however I can. You are muted. That's for purposes of noise control. You do have the ability to come off mute. And sometimes at the end, we may have some discussion and we'll let you know at that point. But for now, if you could stay muted, it just helps with noise control so you can hear all the speakers and the moderator as they go through today's event. We are recording, which means that in 2 business days, you will be able to find this recording on the ACHE website where you find your courses. So when you go in to look at your courses, go ahead and find your course here, and you should see a recording button once it finally posts in about 2 business days. You all are eligible for the 1.5 hours of ACHE virtual interactive education credit. So please make sure that you keep an eye out for that. That does take a little longer. They have to go ahead and do all this stuff back at corporate, but it should post within 10 business days, if not sooner. So just keep your eyes out for that. And if you have any questions, you can always reach out to ACHE and we can assist you at that point. Let's see. Oh, the chat. I want to make sure that you all know the chat is available for you to use. If you want to let us know where you're joining from and give it a try right now, feel free. Most of you may be in Oregon, but sometimes we have people from other locations, which is always neat. Uh, and comments can go in there. But in regards to your questions, feel free to ask them at any point. And we also ask if you really see a question that someone else has put in and you want that question answered, like you are like, yes, that's a great question, go ahead and give it a like, and we'll keep an eye on the likes. And as the questions come in, the ones that have more likes, we'll try to address those first when we get to that point. Let's see. Oh, evaluation link. This is the last thing I promised. Evaluation link that will go into the chat throughout the event. You'll see it. It has a clickable link. You can click on it if you want. It'll take you into a separate window. You don't want to fill that out now, but we do want you to complete that if you can. I will post it right at the end, so you can grab it at that point as well. You also can find it when you go in to look at your courses on the learning management system. So if you miss it, you can do that, and it's up there for 7 days. So we really appreciate if you would complete that. All right. I am done speaking. I'm going to turn this over to Jennifer Will from the chapter, who's going to get us started. Again, if you need anything, reach out to me in the chat, and welcome and good morning.
Yeah, thank you so much, Nan. Well, welcome. Good morning, everyone. I know it's Friday morning early, and we've got people from all over, it looks like, and it is sunny at the coast. So I'm in Lincoln City, so I just wanted to shout that out. So it is great to see all of you, so many of you, in fact. Looks like there were 70 registered today. So I'm looking forward to an engaging discussion today on how behavioral health has such large impacts on healthcare. We are very fortunate to have this distinguished group of healthcare leaders who will share their insights and participate strategies on the path to reducing costs. You're going to learn so much about how behavioral health has such an impact in overall healthcare. So my name is Jennifer Will, and my current day job is Chief Operating Officer for Samaritan North Lincoln and Lincoln City Hospital. Although I will be transitioning over to Peace Health in August, I am the Chair of Education and Planning, so that's why I'm here today. I want to take a moment to share a bit about ACHE for those who are new or thinking about getting involved. So for 85 years, the American College the American College of Executives has focused on one mission, and that is advancing leaders in the field of healthcare leadership excellence. ACHE is the professional home to more than 48,000 healthcare leaders who are committed to integrity, lifelong learning, leadership, and diversity and inclusion. With today's rapidly changing healthcare environment, ACHE remains more committed than ever to being a professional society leaders can count on to help them gain valuable knowledge to improve health for patients and communities. Through an established network of 76 chapters, members have access to networking, earn the prestigious gold standard FACHE credential, signaling board certification in healthcare management. To find out more about ACHE, please visit us at www.ache.org. So the Oregon chapter, which is hosting this event today, strives to be trusted local partner and a valuable resource of continued professional growth. So that's why we get these professionals here to give you some education. So our board members span the state in a variety of roles and organizations, from hospitals to government institutions or higher learning. To find out more, please visit our Oregon ACHE site for upcoming events. We have all of the events posted for this coming year. And please get involved. If you're interested in getting involved in any committees, please reach out to us via website or in this chat. So thank you so much, and I hope you enjoy your experience today. And I'm going to hand it over to Heidi May Stolo, who is our vice chair, who's going to introduce our moderator.
Good morning, everyone. Welcome and happy Friday. It is my pleasure to introduce, and I've been able to work with Mari here for the last couple months, and I think you guys are going to really enjoy this. Mari Stout is a highly experienced healthcare consultant and former behavioral health executive with over 15 years of leadership experience, spanning quality improvement, compliance, accreditation, and operations. As a fellow of ACHE, she's board certified in healthcare management and holds multiple certifications in healthcare compliance, privacy, and ethics. She is particular expertise is in 42 CFR Part 2 compliance, change management, and value-based care. Welcome, Mari, and thank you for doing this.
You're welcome. Thank you so much for hosting ACHE Chapter Oregon, and thank you, Nancy, for creating our virtual space here. You're safe. Everyone, you can take a deep breath. This is not going to be 90 minutes about privacy regulation. I will do my best to not go down that rabbit hole, but feel free to chat with me offline about that. So good morning, healthcare leaders. I'm Mari Stout, and it's really great to be part of your morning. If you're like me, you're on your second cup of coffee and appropriately titrated. I want to start with a simple truth that I believe every person in this virtual room knows in their bones. The person who walks through your hospital doors or your clinic doors or even calls the line at 2 a.m. in crisis is not a behavioral health patient or a medical patient. They're a human being whose mind, body, and spirit are inseparable. Yet for decades, we've built systems and we treat them as if these parts exist in isolation. We've created artificial boundaries between physical and behavioral health that simply don't exist in the lives of the people we serve. And the cost of this fragmentation? Well, it's measured not just in dollars, but through the numbers. And those numbers are staggering, but it's measured in the human suffering that was entirely preventable. Here's what I know to be true. Every emergency department boarding situation, every person waiting in jail, waiting for a treatment bed, every 30-day readmission, every person cycling through crisis without meaningful intervention. These aren't just operational challenges. They're moral imperatives wrapped in business cases begging us to do better. The leaders joining us today understand this deeply. Allison Noyes has spent 25 years proving that when we treat the whole person, for example, integrating maternity care into opioid treatment, expanding access to underserved communities, we don't just save lives, we transform them. Andy Mendenhall leads an organization that recognizes housing isn't a healthcare issue or a behavioral health issue, it's both. David Simmons brings the precision of addiction medicine to the messy reality of healthcare, and that next medicated assisted treatment might prevent the high probability of someone coming to the emergency department with an overdose is still with us a year after that ED visit. And Melissa Thompson fights every day in communities with her teams where behavioral health infrastructure gaps aren't statistics, they're neighbors in crisis. But here's what excites me the most about this moment. We're not here to lament what's broken. We're here because the opportunity to sustainably meet community need and add value in the organizations and the moral case have finally converged. Value-based care isn't asking us to choose between doing good and doing well. It's proving they're the same thing. When Samaritan embeds addiction specialists on medical floors, they're not just reducing length of stay, they're demonstrating that integration creates value that flows in every direction, to patients, to families, to communities, and yes, to sustainable healthcare systems. When CODA expands evidence-based treatment to Washington County, they're not just serving thousands more lives annually. They're proving that when behavioral health thrives, entire communities can become more resilient. When rural communities implement medication-assisted treatment, implement mobile crisis, and if we improve connections between inpatient care to community-based settings, we're not just changing individual trajectories, we're shaping what's possible for healthcare delivery in Oregon. The question before us isn't whether behavioral health or integrated care works. The evidence is strong. The question is, how quickly can we scale what these leaders have already shown is possible? Today, we're going to hear about the real barriers, reimbursement mismatches that punish collaboration, infrastructure expectations that are setting partnerships up for more challenges than they really need, and workforce challenges that require creative solutions. But we're also going to hear about the breakthroughs, value-based metrics that are actually moving crisis interventions that work, and next-generation collaborations that could define Oregon's behavioral health landscape in the next 10 to 20 years. So here's what I believe with absolute certainty. 5, 10 years from now, health systems that thrive will be the ones that have figured out how to make behavioral health integration not just a program they offer, but the way they operate. Collaborate with the community organizations around them. They'll be the ones that are recognized because their emergency departments are critical touch points for early intervention. Their medical floors are opportunities for seamless care coordination, and their partnership with community organizations are essential infrastructure, not nice to have add-ons. The future of healthcare isn't just hospitals plus behavioral health systems and organizations. It's healthcare that naturally and seamlessly and effectively addresses the human in front of us, mind, body, and spirit together. And our panelists are already building that future, and I'm excited to let them share their insights and also their challenges to invite us all together and help collaborate and iterate and make things better. Advance the slide, please. Can you advance? Thank you. So here's a roadmap for us. Our conversation is going to have 4 key areas. We're going to align on the why, patient story, integration models, high value collaboration plays, barriers we keep hitting, and really looking forward, sustainability in the future. As mentioned in the housekeeping reminders, please be welcome to use those reaction buttons to show what resonates with you. Drop your questions into the chat. Heidi, thank you for moderating and spotting those chat questions as they come in. We'll have dedicated time at the end. And our panel is going to move through these 4 key areas, and I encourage you to engage throughout. Next slide, please. So before we dive into panelist introductions and our discussion, I just want to briefly ground us in the reality that we're working to transform. I just grabbed a potpourri of stats from the Oregon Health Authority and recent medical literature, just trying to summarize the challenges that bring us together this morning. But really, people going into healthcare, we're called to serve others. We came into this to help others, not because it's the easy option. So looking at the numbers in the first column, we have a 49% gap in substance use disorder services statewide, according to Oregon's own analysis. Nearly half of what's needed simply doesn't exist. And nationally, we see that only 43% of adults start substance use disorder treatment within 14 days of diagnosis, with just 16% staying engaged beyond 34 days. Those are national stats. Oregon also tracks these with their CCO incentive metrics. But these aren't just statistics, right? They're representing thousands of Oregonians that are falling through cracks in our systems. The workforce picture, equally as sobering. We're missing 94% of prevention specialists that we need, and over half of the prescribers who can prescribe medication for opioid use disorder. Meanwhile, 11% of Oregon Health Plan members have documented substance use disorders. That's over 60,000 people just in the Medicaid population. And as we're all painfully aware of the turmoil that's facing Medicaid. And while we funded the 988 crisis hotline, we haven't fully funded the mobile teams and stabilization centers that would actually respond to those calls, leaving hospitals and jails to board patients. The third column shows broader systemic challenges, cultural barriers that leave most organizations unable to provide culturally specific services, payment structures that discourage collaboration, and persistent stigma that pushes people away from care when they're most vulnerable. This is our starting point. Not to discourage us, because I'm a eternal optimist, not quite Pollyanna, but to be honest about the magnitude of what we're tackling together. And the leaders joining us today are working within this reality every day, finding ways to collaborate through these barriers. Next slide, please. Joining me are 4 leaders who embody that courage. Allison Noyce of CODA, CEO, is leading Oregon's largest opioid treatment provider since 2019. She has over 25 years experience in community behavioral health, and she's currently overseeing state-of-the-art expansion in Washington County that's going to serve thousands more annually. Dr. Andy Mendenhall, CEO of Central City Concern, board certified in addiction medicine and family medicine, is leading Central City's comprehensive approach to housing, healthcare, and recovery services, elevating evidence-based practices across his organization during COVID and beyond. Melissa Thompson, Chief Behavioral Health Officer, Best Care Treatment Services. Melissa has 25 years in behavioral health across multiple systems, a licensed professional counselor and expert in civil commitment law reform and competency issues. And Dr. David Simmons, Medical Director, Samaritan Health STARS program, a board-certified family physician and addiction medicine specialist, current president of Oregon ASAM chapter, and he is leading system-wide expansion of addiction medicine services at Samaritan. I will do my best to contain my fangirl excitement for this rockstar panel. I'm so grateful that you're all here to join, and I just can't wait to hear your insights. Next slide, please. So I want to open it up with a quick round robin for our panelists. I know I gave your introduction, but I want to give you each at least a minute to describe your organization and share one reason why you were really excited to be here this morning. Allison, could we start with you?
Thank you. Good morning, everyone. Mari, your words were beautiful. I was not expecting to be emotional already. I'm also hanging on by a thread in a hotel room in Medford, so fingers crossed on my behalf here. Sorry, I'm taking up time. Again, my name is Allison Noyce. I'm the actually executive director at CODA. We provide a full continuum of substance use disorder services in the Tri-County area of Oregon. So with that Washington County expansion that Mari mentioned, we'll be adding withdrawal management and sobering to what's already a pretty robust set of services that include opioid treatment programs and methadone maintenance, which is quite unique for us and a continuum of care. We do also operate an opioid treatment program on the North Coast in Seaside. Just a tremendous amount of work, something I'm incredibly proud of. I am here today, I think for a couple of reasons. One, Mari said something really beautiful there about how we should understand behavioral health, and I would say substance use disorder services in particular, not as an add-on, but as part of healthcare. And I think addictions work specifically has lived sort of behind a curtain, down a dirt road for so long that we're really not well understood, in some circumstances intentionally not understood. But really, it's such an amazing opportunity to be able to speak in varied rooms about what we do, to help promote that work really on behalf of the people that need us. And so that's something I feel very strongly about. I didn't go into behavioral health to get into addictions work, but it has my absolute heart. I will also say, a couple of those letters behind my name, I went to OHSU to get a master's in healthcare management degree, and was not shocked, but a little dismayed by the real lack of behavioral health representation in those rooms. And so since I finished that degree a handful of years ago, it has really just been a personal mission to put our work in rooms like this, where real leadership in healthcare, real systems understanding in healthcare, gets to hear from people like me and from our work. So thank you. And I suppose I'm just flattered to be asked. There might be a little bit of ego going on.
Thank you for joining us. Andy, I'll pass the next one to you.
Thanks, Mari. Always a pleasure and a challenge to follow Allison. So good morning, everyone. Thank you. Andy Mendenhall, family medicine, addiction medicine, Oregon trained at OHSU and at many different clinics and health centers during med school and residency around the state of Oregon. Truly a pleasure. And I've been an Oregonian since 1991. So I've been around a little bit, most of that time in the Portland metropolitan area. Honored to serve at Central City Concern. I've been here for 8 years. I've been serving as the president and CEO for the last 3. Central City Concern is comprised of a very large, complex system of federally qualified health centers and a continuum of owned housing and employment services. This next year we'll have a run rate of about 190 million, and 2/3 of that is pass-through Medicaid billing in our FQ umbrella. We are a sister organization, very much so, to the continuum that CODA offers, minus the opioid treatment program, with all levels of substance use disorder services and behavioral health care. We're proud to operate Hooper Detoxification Center. As a former CEO, called one of the Ellis Islands to recovery within this region. Very grateful that CODA is opening their Washington County CAT. Which is an acronym I have forgotten the terminology and won't attempt in this moment. But at the same time is another Ellis Island within this region. Across our owned housing portfolio, we have close to 2,500 units of owned or operated housing that run the gamut from stabilization housing all the way through to permanent, affordable and permanent supportive housing. And we also help folks get jobs. So we'll talk a little bit more about the Golden Thread at another point. Why I love this work. I found my way into addiction medicine in 2005 when I was on a city call and admitted a patient with delirium tremens into the local hospital that I was working at down in Yamhill County. And the medical director of a residential treatment center, at the time, the Hazelden Residential Treatment Center down in the Newburgh area, called and said that not a single physician had ever admitted a patient to the local hospital that was a mile away, but rather all of the patient, and that had been an 8 to 10 year history preceding the time that I admitted that one patient. And I became politicized after I became buprenorphine certified, when I had hospital administrators telling me very directly they did not want those patients in our lobby, and they did not want those patients admitted to our hospital. Thankfully, the narrative has changed, and significantly, both within that health system, but also more broadly in terms of thinking about these services in a whole human perspective.
Awesome. Thank you so much, Andy. Melissa, welcome.
Good morning, everybody. Thank you so much for having me. It's a true honor for sure. I'm Melissa Thompson. I'm the Chief Behavioral Health Officer for Best Care Treatment Services. Best Care operates in Deschutes, Crook, and Jefferson counties, as well as Klamath counties. We provide an array of substance use as well as mental health treatment services. So on the substance use end, we provide residential, detox, addiction medicine, outpatient, as well as DUI treatment. We have 2 residential programs, actually 3, sorry. One in Redmond, one in Klamath Falls, and then we have a Spanish-speaking only men's residential facility, the only one in the state of Oregon, in Madras, which is located in Jefferson County. For Crook and Jefferson County, we are also the Community Mental Health Program, the CMHP. So we are the safety net services for mental health in general. So we provide crisis services, assertive community treatment, which is a program specifically for severe and persistent mental illness, wraparound support for children and families, as well as many other kind of safety net services that the state of Oregon requires each county to have. So we really run the gamut in terms of, from mental health crisis to addiction medicine crisis and everything in between. We've been around for about 25 years and have grown substantially over that time. For me, I'm a therapist by trade and an addiction medicine a counselor as well. And so I look at the whole person as a whole person. I don't think it's possible to separate things out. And when I look at the barriers and the holes that people fall into throughout our system, it's usually a result of us thinking that we can kind of focus on maybe one particular thing and not look at all of these other factors, including social determinants of health, as well as how the physical conditions interact with the behavioral conditions and vice versa. I'm a huge proponent of community partnership. It's the best part of my job. I love working with our community partners and the ability to break down barriers amongst each other to genuinely help that whole person approach. And so, is it completely out of the ordinary for a probation officer to have a good relationship with a therapist, to have a good relationship with a hospitalist, and how do we break down those barriers so that we can genuinely treat the person, reduce costs overall, and be a better community in general. So thank you so much for having me here, and super excited.
Welcome. And Dr. Simmons, David, welcome. Good morning.
Hi, good morning. I'm David Simmons, joining you from my crepuscular hidey hole in Lebanon, Oregon. I'm the Director of Addiction Medicine for Samaritan Health Systems, which is a 5-hospital integrated system that's integrated with a CCO, Intercommunity Health Network, across Lynn, Benton, and Lincoln counties. Yeah, I'll say I straight up feel like an imposter with these 3 other panelists whose work I have so admired. I'm a latecomer to the industry. I went to medical school at OHSU in 2010 after quite a few years of experience in addiction treatment. Never anticipated that I'd be doing addiction medicine, but it runs deep, and Andy's story is so telling about the attitudes about those people. I love those people, and you do too, because it's everybody's family. It's people we know and love, so it's an honor to get to be here and with these folks and with all of you.
Awesome. So I think the audience now can understand why I'm feeling fangirl excitement over here. So without further ado, we'll jump into this discussion. Really, our first section is aligning on the why. Now, we're here because behavioral health integration isn't just good policy. It transforms lives and adds value. So Allison, I'd like to start with you. Can you please share one patient story that shows how the right time behavioral health care can change inpatient trajectory and cut avoidable costs?
Thank you. This is such a fun way to open this panel, I think. I love this story. A little bit of background on some work that CODA has been a part of for 10 to 12 years now. Shortly after the formation of CCOs in Oregon, sort of post-Medicaid expansion, CODA had the great fortune to be asked to start a project called Project Nurture. It still exists. It's spread in various places around the state in a few different iterations. But the spirit of it really was meant to be the integration of addiction services and prenatal and postpartum care for women who are substance use disorders. So we took a very unique path as the opioid treatment program. We are already mandated and expected to prioritize the treatment of pregnant women using opioids. Methadone has and continues to be the gold standard in those circumstances. So it was a patient population we had been working closely with for a long time. So we integrated family medicine into our opioid treatment program. Fairly unheard of and quite an interesting path. So the point here being CODA in particular, and I will say this, OHSU Family Medicine as well, who is our partner, both of us really were quite accustomed to a patient population who was really very high risk, very high need. So these are often our patients come to us having for substance use disorder care, having repeated multiple episodes of care on and off of medications throughout their life, in and out of treatment. The family medicine model, similarly, really accustomed to a pretty complex set of circumstances. So we had women coming to us often late in their pregnancy. We, wrapped a ton of service around them, both prenatal care, doula services, mentor services, medication-assisted treatment, all the bells and whistles of addiction services as well. And again, our typical patient was one who was often multi-system involved and had been multi-system involved many times in their lifetime, if not generationally. So many had previous experiences with child welfare, with separation from children. Many had very terrible experiences with the health system previously. So there are few people who are shamed quite as deeply as a pregnant woman who uses drugs. And so our hospital systems had really treated them very poorly for quite a long time. So they come to us with a tremendous amount of fear, with having experienced a tremendous amount of trauma already. And so here we were really providing them this immense amount of care that was loving and non-judgmental and integrated, and we were having a blast. But it's hard. So after having done this work for 2 or 3 years, had built really strong pathways in and out of the hospital, had done a tremendous amount of work helping these women be less afraid of the system itself. I had a moment where I was listening to a story about a woman who had come to us where it was her first pregnancy. She stabilized on methadone. She received prenatal care. And as she was getting ready to deliver, it was clear there was no trauma to undo. This was a woman who had a very normal experience of pregnancy, delivery, and postpartum care. And it was such a moment where, we become so used to these individuals who have suffered so, and who we have to really help through these systems, to have a moment where I realized we had built something that really protected this woman from the entirety of those challenges. Immensely proud moment, and just so excited to think about that woman, the experience of her delivery, and to the point of why we're here, everything that was avoided in terms of cost and system utilization. But really, more than anything, it was beautiful to think about her and her new child.
Wonderful. Thank you. I mean, so you talked about multi-system involved individuals, multiple rounds through those multi-systems. I mean, it's no wonder, right? We have a complex system as it is. And these are vulnerable populations needing help getting navigated through that, but also having care, really putting them in the center and designed for them. Thank you, Allison. I want to move to David. I think this gives a nice segue. Though she didn't use the term, the term integrated care gets used frequently. Yet models range from simple referral coordination to fully merged medical behavioral health teams under one budget and one medical record, right? It's a pretty vast continuum. David, how do you define integrated care along that continuum? Where does Samaritan Health currently sit, and what specific step would move you one notch closer to full integration?
I think in terms of level setting, I think about a patient who experiences a STEMI, and what's that? What kind of resources do we mobilize in a situation like that in terms of integrating transportation, referral, tracking outcomes, and that sort of thing. Yet we can take another disorder that's essentially got the same risk factors that lead to it, and I'm thinking non-fatal opioid overdose with the same 1-year mortality rate. And our response is to say, here's a phone number, go call somebody and take care of it. So when I think about a model for integrated care, I think about marshaling the same sorts of resources for folks with substance use disorders. That is, everything we can get our hands on. So looking at that inside of Samaritan, what we're aspiring to is the entire spectrum of addiction treatment fully integrated into primary care and hospital care, from a consult service in the hospital through withdrawal management, through residential treatment, through outpatient treatment, wrapped by peer support services and counseling, and a clinic for medications for addiction treatment, and aspirational even is what they're doing up at Central City, right? And housing, or I think all of you folks at your institutions have. Now we've got some big gaps there. That's housing is not something hospitals have done, recovery residences and that sort of thing. But there's sure a lot of people in our community who do. Chance, Emergence, Milestones, all of these organizations across our communities. And so in addition to integrating our own resources, our big mess has been integrating with all of our community partners. And making sure that we are meeting, we are talking, we have not just memoranda of understanding of how we're going to do this, how we're going to step people from one service to another, but actual personal relationships. And I think specifically of ROTP in Albany, Oregon. Their program director is a former employee of Samaritans. And so we've got that personal relationship, and our ability to integrate methadone into our residential treatment program was completely contingent on the fact this guy had goodwill towards us. So I think if I could have one thing, and this, I'm pushing for this really hard, it's truly a system of collective impact across these 3 counties, where all of our burn partners get together. The leadership of these organizations get together in a virtual room once a month and talk about, okay, who's doing what? I got this, I got recovery residences. Okay, great. I got an inpatient consult service. I'll figure out how we step down to your facilities. We can really do this.
I love that. I want to also ask Andy the same question for Central City Concern. How do you define integrated care, and where's your organization on the continuum, and what's your next step?
Thanks, Mari. So CCC, we're really proud that, within our health centers, we have fully integrated psychiatric prescribing, psychiatric prescribers, and every every frontline medical provider is providing medication to treat opioid use disorder in the form of buprenorphine or long-acting injectable buprenorphine products, as well as medication to treat alcohol use disorder, typically in the form of naltrexone or depo-naltrexone. I'll also say that, in our health centers, our frontline sort of more traditional primary care workforce of family nurse practitioners, physician assistants, and family docs and general internists are all expected to be advanced psychiatric prescribers. And so, from the ground up, I think it's really important to have a clear expectation of defined scope of practice for different types of providers, and to recognize that for some folks that might not be in the background of their journey. But what we don't accept as a culture is, oh, that's actually outside of my scope, or that's outside of my training. Number one. And number two, as an organization, we say very clearly that there will always, unfortunately, be level of care or level of service mismatches if we look at what folks need versus what they probably have access to today. And we just say, hey, that has to be acceptable in an environment, in an ecosystem that does not have enough access, and it will take years for us to close that access gap. So I wanted to start really within, the healthcare aspects. There's other areas of Central City concern and that David alluded to, where we're proud to have co-located behavioral health services, and in some cases, primary care, little micro clinics that are co-located within different parts of our housing continuum as well.
Fantastic, thank you. So this first section of our discussion, right, our panelists have talked about collective impact, systems thinking, really making full use of community resources, as well as optimizing the connections, right? Not just optimizing the parts, but how they connect together. So I want to move into our next section. If you could advance to next slide, please. And give our panelists a chance to talk about the very real barriers that we keep hitting. Andy, I do want to come back to you to kick us off again in this section. And let's be honest, right, about persistent challenges. What infrastructure expectations are most often overestimated by hospital partners or other community partners? How has that mismatch stalled or derailed any recent collaboration? Maybe what practical adjustments would help remove those obstacles?
Thanks, Mari. I'm gonna answer the question through that lens of how we see our hospital partners struggling, and I'd say that there are two key elements, and that our hospital partners, I think, overestimate, certainly within this region, with good intention, right? And the first is access to behavioral health care and substance use disorder services, in particular, access for high acuity psychiatric patients or high acuity dual diagnosis. And by that, I mean, there's a psychiatric condition, there's also a co-occurring substance use disorder condition. We simply have not, as a state, built the infrastructure. Rates have not incentivized sustainable infrastructure construction over time. And unfortunately, over the course of the last 5 years, rising acuity, in particular in that dual diagnosis population, has actually driven growth in the population that needs those higher acuity services to both achieve stability, but also maintain stability and service engagement over time. And so, that is one of the key challenges. The second is housing of all forms, inclusive of housing for lower wage employees of hospital systems. So I want to include workforce housing as, a regional challenge for most communities, both urban and rural, within the state. And, I would say, I think one of the key strategies that's really important to highlight is that if I were a hospital administrator, I would be doing my best to ensure that if I'm lodging psychiatric patients on a medical floor, or if I'm lodging folks with high acuity dual diagnosis in an ED, who are oftentimes negatively impacting HEDIS metrics with recurrent readmission, right? Due to relapse, due to lack of other service engagement, due to lack of housing out in the community. I would be aiming to ensure that the hospital and or the service teams were staffed to create the most stabilized patient as possible during the course of that hospital admission, number one. And number two, hospitals are one of the few entities that exist that can actually do bonding. Bonding in a way that could potentially empower through finance the construction of the very housing that their workers and their patients could potentially benefit from on either a short-term transitional or stabilization post-hospitalization approach, think respite care, right? Or long-term affordable housing within the communities. There are examples in many communities where this type of robust strategy has occurred. And there are other examples, in particular the Arizona market, where there's very high penetrance of a for-profit Medicaid system, where subsidiary or parent investment of those for-profit Medicaid systems have ensured a higher per capita, a much higher per capita affordable housing percentage, because those folks in those systems know that lack of housing actually drives excessive cost within the Medicaid population in particular.
Thank you. Melissa or Allison, anything you want to add on to that?
I was just going to say, I mean, there are barriers, I think, kind of in all aspects of behavioral health. I know there was a question in the chat just about kind of the barriers of accessing psychiatric treatment, accessing state hospital, and kind of the criminal justice involvement that inevitably occurs when we don't have a system that is designed to really treat folks at all levels. I think, you know, as you mentioned earlier, when you don't properly fund something like the mobile crisis system, and that system is a continuum of care, it's not just you know, counselors going out responding to a crisis. It's having stabilization centers, it's having respite centers, it's having all of these steps before that person ever has to go to the emergency department, which is going to be the most expensive option. And when we don't have those, it causes all the other systems that are designed to treat what they're designed to treat, or criminal justice is designed to sort of house, right, you know, people that commit crimes, and not house folks that are mentally ill doing things as a result of their mental illness or as a result of their substance use disorder. It causes all of those systems to become overwhelmed and have to adjust and ultimately break down as well. So, so I think, you know, there have been this particular session, there's been a lot on this particular topic. There hopefully are going to be significant investments in additional facilities and housing opportunities to you know, fill those gaps for those continuum of care placements. But it's an ongoing challenge. The payment system does not support what we need in order to really address all of these issues.
And Allison, I was going to offer you the follow-up on that one, but I'd actually, in interest of time, want to move on to our next question, which I was going to pitch to you anyway. Really around, where does the current reimbursement disincentivize collaboration or make doing the right thing for patients harder, right? We were just talking about these persistent challenges and infrastructure, and payment is part of that reality. How are you pushing payers or legislatures to change that?
Yeah, this is a way better answer anyway, so that's fine. The particularly for substance use disorder services, and again, I'll acknowledge I work almost exclusively in Medicaid, so that is 100% the world I live in. And I know there are commercial systems that perhaps behave differently. They have their own flaws. The addiction services is by and large fee-for-service reimbursed. And it is really, really holding us back, right? There's a simplicity to it that I think, given the fact that as a system we've not been invested in, that it works for us. There's a short list of codes. It's pretty easy to either know you did the service or didn't do the service and who did the service. So ring the bell, get the dollars. The reality, though, is that fee-for-service system really disincentivizes collaboration. It disincentivizes specialization. And so it is what has compelled us for, I think, decades to try to be everything to all people. I have a slightly unpopular, I think, opinion about whole person care. I believe these are whole people that need really whole person care, but I don't always believe that an entity has to be capable of all those things. We should be good partners. And that's really what we work to do. So we can specialize in what I think we are expert at. It's very hard to be expert at everything. Tangent. So the fee-for-service world has really kept us from patient sharing. If the patient's not mine, I'm not getting paid. If they're getting care from you, I'm losing money. And so it has forced and the rates being as low as they were for so long, it has really forced a competition that is completely unnecessary. So I think the payment model for addiction services is keeping us in the dark ages. But you have to also appreciate we have not been invested in as a system for so long that you can't sort of move us directly into a very sophisticated payment model and expect us to have the infrastructure, have the data collection, have the knowledge of how that works. So I think there is really, there's going to be, to get us to a better payment system, there has to be a real willingness to invest in us upfront and bring us along. But I'm anxious to get us there. I also think that fee-for-service environment and so much about how we think about addiction services in general is the antithesis of the chronic disease model. And we have been mouthing the fact that a substance use disorder is a chronic disease for decades. We continue to pay for it and treat it in an episodic way. We continue to ask treatment providers to speak to completion rates. How many chronic diseases are measured by when somebody stops treatment? Right? So wild on a number of fronts. So I will say we have had some good success, specifically in our opioid treatment programs. Our Metro opioid treatment program is in particular because it is has such a volume to it and has such a long tenure of patient care. We can really look at those patients as populations, right? So we're trying to figure out, how do I understand the patient need, the patient preference, and the longevity of patient engagement, right? And modify where I put my staff resource based on those things. So we have in both our opioid treatment program in the metro area and in a slightly different way in our coastal opioid treatment program have had really some pretty positive early success with models that are a combination of what we're accustomed to, but push us into a new mode of thinking. And so those are combinations of, in one case, continuing the fee-for-service model, but layering a per patient per month so that we can really meaningfully provide team-based care, so that we can engage systems like point-click care and really do a much allocate resource and people and time to integrating internally as well as integrating with the systems outside of us. There's also, I think, a model that I'm playing with that is even beyond fee-for-service, is more of a base payment plus a PMPM that sort of modifies as census grows and can motivate growth. So we're trying some cool things there, and yeah, I think as an opioid treatment program, we're just so sort of novel in a lot of ways that actually, if you take it and run with it, we can really, I think, push the envelope with it. So
Thank you. You give such a great bridge answer. I couldn't have asked you to do more in between the infrastructure need, even to call out, right? The High Tech Act excluded behavioral health, right? So implementing EMR is still pretty fresh for a lot of behavioral health organizations. And you gave us a great segue that I want to pitch to David about this resource allocation choice, right? So this next question gets to the heart, right, of resource allocation decisions. When funds are limited, how do you decide whether to put the next dollar into residential or withdrawal management beds, or expanding into medications for opioid use disorder or other community outpatient services and supports? So David, how does Samaritan approach this? Is there one metric that guides your organization's thinking? How has the organization's decisions played out?
I think in terms of allocation, well, Allison brings up a really good point, that we can't be expert at everything. We can't be all things to all people. There's a real push in our community appropriately for withdrawal management. In our 3-county area, there is no detox. And we had the experience of, we're expanding to the coast and building a residential treatment center at 3.5 in Newport, and that's going to be opening later this year. And you know, I think when we started on the project at the beginning of the pandemic, we anticipated a budget of $4 million, and you know, now that's 14 million or something like that. And so when we're talking about building a detox in our community, the idea of the cost of both building it and staffing it with RNs, et cetera, it's simply unrealistic. And then, as Andy says, we're in a rural community. There's no housing, or we do it on the coast, right? The housing costs a fortune out there. It's not going to happen. I think where the smart money is in terms of return on investment is there is a certain slice of folks who are going to need residential withdrawal management, alcohol withdrawal, especially complicated alcohol withdrawal. But there's this wide swath of folks who don't necessarily need a medically monitored bed. Somebody who wants to be getting started on buprenorphine. We could have an army of resources in an ambulatory setting who could meet with these folks in kind of a partial hospitalization setting, and do this in an ambulatory way, have peer supports, have meals, have community resources involved in this collective impact model who can connect with patients there, work on getting housing and that sort of thing, and really try to keep the cost manageable and the impact maximal. The trick is paying for it in a fee-for-service system, right? And a thing that Heidi has heard me talk about, Heidi Maestolo, my dyad partner here, ad nauseum, is the bundled payment codes in Medicare G2086. That's essentially per member per month, and then per time for additional time spent in coordination. I think that's a realistic way for us to try to get a handle on this. But nobody's using them because nobody's quite figured it out yet, unless I'm mistaken, unless you guys are all using them. But so I think there really is a way that we do this to surgically target the resources to the individuals who need them and find precisely what's needed, and supply it in a non-hospital setting.
Thank you. And in the interest of time, I am going to advance us to the next section. Man, I wish we had like 180 minutes because I'm so excited to hear your insights from everyone. But if you can advance to the next slide, I think what David just shared about, there are bridges, right, being built. There are ways that we can try and fund and provide the right care at the right time. So these are aspects of examples of high value collaboration. opportunities. You know, maybe you haven't implemented at your organization, but maybe another one has, and maybe they can share what worked and what didn't, right? Because we're all doing this for the same shared goal of doing what's right for the patient that can add value to our communities and be sustainable for our systems, right? I don't know a single area of healthcare that does not have a workforce problem. So AI isn't going to solve that for us, right? So we are going to have to look at how we're using our resources and in the community. What, like Allison said, right? We don't have to be experts in all things, but we can connect and fill in the bigger picture together. I want to move to Melissa. So in terms of the hospital as a critical touch point, when a patient hits the ED or an inpatient unit, it's often the one moment hospitals and community behavioral health teams overlap. Melissa, can you share one way that you've used that touch point to improve follow-up care and one change that would make that connection even smoother?
Yeah, so we're really fortunate. We have a great partnership with our local hospital, and our hospital is actually the same hospital in all 3 counties. And so we have our we have a CET program, which essentially we have peer support embedded in the emergency department as well as on the medical floors. And so when somebody comes into either of those settings with some sort of substance use disorder presentation, we have folks that are there, and nursing or docs will say, we have someone here that, you know, is able to talk to you about any next steps. Are you open to that? And at that point, we're able to make those connections. You know, peer support they're the magic formula to so many things. Their ability to connect with folks in a way that myself as a clinician or a practitioner maybe can't, really helps bridge the gap. And so we're able to, you know, transport folks from those settings to our rapid access addiction medicine clinic, where we can just literally, you know, have them walk in. We have our clubhouses and our burn centers, where if we need to get them food or, you know, any kind of clothing, we can do that and really get them connected with services right away. We have the same partnership with our maternity floor, because we have a subsection of Allison's amazing Nurture Oregon program. And so we have social workers call, the peers go there, get folks connected to services. You know, the challenge certainly is that while this sounds amazing, and it is when it works, we have reluctance oftentimes, right, from various hospital staff to call, or depending on how it's presented to the patient of who wants to come in and talk, depends on maybe how willing that person is to let us come in. You know, these individuals that come into these settings are challenging, and they create a jadedness that exists. I know I'm not saying anything anyone doesn't know, but that's just the reality. They're really hard folks, especially if maybe that week this is like the 3rd or 4th time you've seen that person. So so we really try to have regular engagement with hospital administration and nurse managers and all the things of like, hey, we were there, you know, no one called us on this person, what was going on here? And we try to really follow up so that those holes don't continue to exist. And then, of course, when somebody is placed on a psychiatric hold, we have that immediate engagement from our community mental health programs to investigate that hold and try to help that person get connected into services if ultimately it's not going to go to a civil commitment, or even if it is. And so, yeah, that ongoing communication and collaboration is just really, really important. We have door-to-door service. And so if you can have that seamless transition, it can really help for sure.
What I hear you saying, well, a lot of awesome things, but one thing that came to mind was how trust is built more effectively when there's another human there offering to hold your hand to the next step than handing the patient a phone number.
Absolutely. Yeah. And just, understanding the cycle of addiction, right? Like there are these magic windows that open for people. And if you happen to be standing there when that magic window opens and you can help them walk through it, you're able to get a success that is, they're fleeting. They're these fleeting moments. And so when you have that human connection there, it tends to go better. So we try to be there as often as we can.
Thank you. Andy, I'm going to come back to you because I think what we talked about right there was around these connections. Yet we know we have gaps from when someone is diagnosed with a substance use disorder to when they first engage and get treatment. And David brought up earlier, detox. Detox is not treatment, right? He really emphasized the connection to ongoing, like the next step that is treatment. Where it's a sobering statistic, only 43% of adults start any care within 14 days of a new SUD diagnosis, and just 16% stay engaged for more than 34 days. Andy, I'd like to start with you on this, and if we have time, give our other panelists a chance to add on, but what's one practical move? Workflow, staffing, tech. What is one practical move that has noticeably raised the share of patients who complete a referral from physical to behavioral health care? And how do you know it worked?
I'm going to offer one that's concrete and the other one that is literature-based but underrepresented in Oregon. The first is recovery peers. Recovery peers and the investment in the recovery peer continuum has made a profound difference for us. It's measurable. I can't give you a hard number, but it's made a measurable difference for us in terms of that connection from street to withdrawal management in this region. It's also made a difference for longitudinal engagement and re-engagement when folks are in their early recovery phase. And it's also one of the primary investments, one of the primary strategies that was represented in the Measure 110 investments across the state. How's that work? It's really about connection. It's about amplifying that this is a process in a stage of change and management of a chronic disease state, as Allison stated. And I'll also say, as well, as the drug supply has changed, particularly as opioids shifted from predominantly prescription drugs and heroin to prescription opioids and heroin to fentanyl. The first 30 to 45 days of engagement has been a completely different scenario. It's a completely different clinical manifestation than we observed for opioid use disorder even just 7 or 8 years ago. So that human connection with peers is the #1 intervention that has been meaningful within our continuum in the region. The second piece that I would just call folks' attention to is contingency management, and broad-based contingency management is the concept of offering an incentive. There's a lot of science behind it, an incentive for remaining engaged in treatment or services, an incentive for successful mileposts or stage gates in terms of somebody's treatment goals being achieved and or the recovery experience writ large. In our neo-Calvinistic society that continues to struggle with the stigma associated with substance use disorders, there has been political resistance to the funding of contingency management programs, and I think it's something that we must consider as part of as part of solving the engagement gap that you've identified.
Thank you. And we can't solve it alone.
No.
All the easy problems have been taken. Darn it. I'm just taking a quick look at my clock. I have 3 of them up to try and keep me on time. And it's reminding me that I am an internal optimist, and we should advance to our last section. And I want to give one last question and have each panelist take a minute and give a response so we can get to the audience Q&A. Thank you. So topic is rural behavioral health needs. And I realize a couple of you, are more based in metro systems. So feel free to modify your response however you wish. But there's compelling evidence for what's possible in rural areas. And when I think of this, it's also just resource limitations, right? So I think everyone can relate to that. A study in a 2025 study in the Journal of Addiction Medicine found that rural Medicaid patients who received medication for opiate use disorder had 24% fewer ED visits and 52% fewer inpatient admissions over 30 months, compared with matched peers who never started medication. So we'll start with Allison, and work our way around. What's one change in design, policy, or partnership collaboration that you think would let our communities see similar results?
Speaking from our experience standing up an opioid treatment program on the North Coast, transportation is everything. And I will largely point to all the things and assumptions we made that were incorrect when we went out there. But transportation, we thought we put our opioid treatment program in a place that was centrally located, so a number of communities in different cities and townships could get to us, and they don't. And that is access to reliable transportation. That is, there is a lot of cultural and I think just cultural and geographic limitations. People don't move around a rural community in the same way they move around the Portland metro area, right? So we have to figure out how to support people in literally getting to the care where it is at. And I don't think telehealth is I think telehealth has a role, and there are limitations of telehealth, particularly in rural areas when you think about connectivity and data and different kinds of access. And so I think there are some real just city infrastructure, there are some infrastructure issues that can go a long way in helping people really get access to the care or helping us become more mobile. Whatever that takes, we have to be able to move differently around these communities. And I think the moral of that story is, and people who know rural health work, I'm not an expert by any means. You cannot take metro solutions and shrink them to be rural solutions, right? So building integrity and reputation in a rural community takes a lot of face-to-face. It takes a lot of time. There's a lot. So it takes patience, and that means providers who are taking the time to stand something up out there need support to stay whole while they do that. And it is slow.
Thank you. David, to you, lightning round. What is the one change you think would let our community see similar results?
Standing orders for buprenorphine to start in the field via EMS and a peer support along for the ride.
You just gave us extra 45 seconds. Bless you. Okay, to Melissa.
Yeah, I mean, so Jefferson and Crook counties are rural counties, but they're actually very different rural counties. And so having the staff, we don't have individuals to do the work. So really investing in what does that take? What does that take from, high school level up, really investing in educating folks on what kind of career options there are, really supporting that when maybe generationally their families have never gone to college or have always just gotten a GED. And so really helping support that from, like creating that pipeline and really educating the community. We have two very different rural communities. One community tends to support those that struggle, and the other just wants them to go away. And so really, really investing in those relationships, really investing in the community partnerships so that we can continue to educate each generation as they are coming up, to reduce that stigma, to give opportunity to have conversation, to give opportunity to ask questions, and to slowly sort of chip away at the preconceived notions of what, quote unquote, these people look like, how to help them, and how to really incorporate them back into the community that they have lived and were born in and have been raised in. So I love what Allison said in terms of historically the state has tried to just take what works in maybe 3 or 4 counties in Oregon and just apply that everywhere else. And that is like an instant way to get that community to say, heck no, we're not doing this. So that's really what happened. So really understanding the rural and frontier regions of Oregon, and really investing in what they need.
Thank you. And David, excuse me, Andy, lightning round.
Doing my best to build on the themes here, particularly with respect to MOUD. And the outcomes driven by access to MOUD. I think that in addition to field-based standing orders for EMS, I think we need to really evaluate the role of corrections health and healthcare in carceral settings as a core anchor point for both the provision of MOUD, but also for psychiatric care, number one. Number two, I think that every person that has a DEA certificate is morally obliged, but should be professionally compelled to become a buprenorphine prescriber. And that requires a meaningful community of practice engagement. And last but not least, I want to honor the longstanding history of the recovery community and the persistent, at times historical resistance to the concept that taking medication as part of a recovery journey is consistent with recovery. And that continues to be a challenge even within the metropolitan region. And in the face of, the catastrophe of the fentanyl epidemic as well. That's something I think is of value to continue to explore regarding the establishment or maintenance of barriers in carceral settings, in correction settings, in our regional and county court systems, as well as in the general population writ large.
Thank you. Thank you, panelists, for all of your insights. I really wish we had more time, but I do need to get to our audience questions. Heidi, what do you got for us?
Yeah, so thank you for being engaging. And I also wanted to thank the panelists because they actually jumped in and helped kind of answer some of them. So my hope is I'm going to go to ones that haven't gotten an answer quite yet, and then we'll jump back to the ones that maybe have a slight answer. So there was peers who are culturally diverse, and providers who are culturally represented are so important for rebuilding of trust in behavioral health system. What programs exist that incentivize diversification of this professional field? So what programs exist to incentivize that diversity in this professional field? I'm not sure who you want to take that away with.
Anyone on the panelists, I'll just open it up. We'll do lightning round on these questions. So around workforce development and specifically around peers.
I'll take my perspective, not much. And there's, an opportunity for us to deliver specialized care and get an improved reimbursement rate from Medicaid, but not enough. And so for us, figuring out how to do that is critical.
And I know we're short on time, so hopefully ACHE won't slap my hand on this because we didn't give a full 15 minutes to questions. I'm happy to follow up with panelists afterwards with questions, and we can give some more expanded answers. I hear a thumbs up. That's awesome. Just in the interest of time, Heidi, can you
Yep.
surface another one?
Yeah, so how about I've heard that it requires 1-hour visits from an LIP to refer someone to withdrawal management. What can which can pose as a bottleneck and barrier due to the lack of availability of the LIPs on nights, weekends, etc. Is the lack of that change more about keeping barriers in place so as not to overrun the system, or just a lack of agility from the state changing rules to increase access to treatment? So I think the question is just like, it's a bottleneck if we don't have a lot of licensed independent practitioners. So why do we keep having that, and where's the change going to be? And it sounds
I
like
think
Valdez said that might be a question for OHA, so we can move on to that. I believe it was his question too. So
Allison, did you want to
I
make remarks?
actually, I mean, I will say, I think Valdez is right in answering his own question. It is a question for OHA. But I will sort of say it speaks to, for folks who aren't familiar with how behavioral health services in Oregon are licensed or certified, the administrative burden that is, it's a phrase that we're using a lot. And frankly, it's going to lose all its meaning soon. But there is so much that we are compelled to do at a level of detail in our regulations that is not what you see in a primary care environment. In many other medical settings, there is an assumption that the licensed practitioner is responsible, ethical, and provides quality care and knows their scope, right? So they practice their medicine. Our systems do not come with an assumption of competence, and so we have been regulated to a point that is unnecessary, lacks clarity, and that if I am tracking Valdez's original question, I don't think that's required. But I think what you have is a variability interpretation, both on the provider's perspective as well as the auditor's perspective. And then we, as the provider, have to be accountable to so much within our own record. It is why we continue to replicate work over and over and over again. We hate the fact that we're assessing people 57 times, but if I haven't done it in its entirety in my record, I'm at risk for looking non-compliant. It's wild.
And the regulatory burden, part of that, like privacy. I just gonna say, I went almost 55 minutes without saying part 2, but that's another right there. It doesn't have to be a barrier. There can be information shared if you have the full picture and conversation with those community partners and train the frontline staff. They should not have to interpret federal regulation on the spot. Heidi, do we have time for a couple more?
Could I
Dr. Mendenhall has
on that?
his hand up.
Oh,
I just want to amplify everything that Allison said, and that's certainly our experience in our dedicated licensed level 1 and level 2. Well, quite frankly, our residential, so our level 1s through 3s SUD programs. Spoken pretty crudely and bluntly in my typical FP way, it's the value of embedding these services in primary care. At the end of the day, we as a system and our regional CCO made a really valiant attempt to try to expand MOUD prescribers in the region back between 2015 and 2018. And quite frankly, and they tried to do that within the BH system of care, and it fell flat on its face after a couple $1 million investment, and not despite anybody's good efforts or positive intentions. Where expansion happened, in particular for medications to treat opioid use disorder, certainly as a front door, right? To then, creating initial stabilization, early recovery exploration, and then referral up to a higher level of behavioral health care. It happened in primary care. It happened in primary care because it was nimble. And tragically, the same provider working in a primary care clinic is still paid more, or the reimbursement is still more than the same provider working in a licensed SUD program, which speaks to the insanity of the current rate structure.
Thank you.
I would like to do one more question because we haven't really touched on this. But is any of the panelists work with the pediatric population, and any specific issues with that population would be helpful to hear? I think if no one does, it also speaks volumes of the need in the state. But go ahead, Melissa.
Well, within our community mental health programs, our CMHPs, we serve children and families, you know, we have in Crook County there is Rimrock Trails, which is an adolescent SED treatment facility, inpatient, and then they have like an outpatient sort of setting that they do aftercare. But yeah, you know, I mean, I think what we see in community mental health is we see kind of generational issues that then impact the youth that we serve. You know, we certainly have a homeless youth population in each of our counties that we are trying to utilize, you know, a variety of our programs, young adults in transition, wraparound services for folks that are, you know, involved in multiple systems, child welfare system, criminal justice system, healthcare system, to just, you know, again, educate, reduce risk, provide that treatment. But it's challenging, right? I mean, when you have an issue with a youth that stems from an issue with a parent, we have to sort of treat, just like we've been talking about treating the whole person, we have to treat the whole family. And that becomes challenging depending on where that person is in terms of their stages of change. So, but yeah, it's an ongoing challenge in terms of not just the treatment, but finding the providers to be able to do it.
Any other panelists want to add on to that?
I might comment that pursuant to the administrative burden, it is an entirely different set of regs and certification to be able to care for adolescents. But it's breathing down our necks starting in January. Adolescents will be coming out of carceral settings with Medicaid. We better figure this out fast, and so we're doing our best, because I got access to pediatricians here, and family medicine docs here, so I feel that responsibility. Samaritan feels that responsibility.
And I put a plug in to go to the Oregon Health Authority's website. They have the strategic plan, and they give good detail also about where they are making investments. Investment funds are already flowing, more is coming. So I think that can also help paint a picture at what we're trying as a state to put in place for very real gaps that we have known have been there for a long time. Thank you to our exceptional panelists, and Allison, Andy, Melissa, and David, for sharing your expertise and real-world insights. Thank you to our audience. These leaders have given us concrete strategies and honest assessments of both opportunities and challenges in behavioral health integrations. Behavioral health, we want to collaborate. It is going to take us all. Complex issues, please don't design in isolation. The work continues, and the partnerships you build today may well be the ones that transform the care in your communities, especially for these vulnerable populations that have been underserved for far too long. Thank you for joining us this morning. If you really enjoyed our session, please tell Oregon ACHE that you would like more on behavioral health. And contact information for our panelists and additional resources will be shared in follow-up. Have a great Friday.
Thank you.
Thanks, Mary. And that does conclude our session. Everybody, I put that link in the chat several times. I'm going to do it one more time. What can I say? Outstanding. Very, very great session. You'll be able to watch the recording if you want to listen to it again. I wish we did have more time. But on behalf of ACHE, that does conclude the session. It is copyrighted in 2025 by the American College of Healthcare Executives. All rights are reserved. Thank you, everyone. Have a wonderful weekend, and the best to everyone. Thank you.
Have a blessed day.
Bye. Good job, Mari.
Hey, thanks.
Thanks, everyone.
Thanks, everyone.